And without further ado, I will turn it to Mark Humowiecki, and you have his title and affiliation. Maybe you could say a couple words on about the Camden Coalition, since the topic came up.
Sure. Thanks, Murray. And it's a real pleasure to be here as part of this conference. I have no problem accepting the sort of title of small. We recently passed 100 employees, and that to us felt like we were enormous. So we are a small nonprofit in Camden, New Jersey. There's been a nice lead up. Some of the comments in the last session and even before, I think, sort of introduced our topic of hotspotting and sort of the work that we've done in Camden. For those of you that do know of us, many of you probably learned about us first in the Atul Gawande article in 2011 called The Hotspotters. For those of you who don't know us, Camden, New Jersey is a sister city to Philadelphia. It's across the river, the Delaware River. It's a town of 77,000, 9 square miles. It was once the home of the Vitrola and RCA Music. It's fallen on harder times and is suffering a lot of the same ills that many sort of post-industrial cities have in terms of high rates of poverty, violence, unemployment, and so on. So the story of the Camden Coalition starts about 15 years ago with the start of a breakfast group for primary care providers. Jeff Brenner, who's the founder, talks about them as a group of sort of malcontents who were complaining about declining Medicaid reimbursement rates, new investments in hospital wings, and just sort of healthcare going in the wrong direction. They came together as a form of community organizing within their own tribe and started working together on shared problems. Eventually, a lot of the economic problems didn't really change, and you can see in this slide, Jeff's office boarded up. After about 6 or 7 years running the Camden Coalition as a side project, he actually had to close his practice and was full-time sort of running the coalition. Like I said, we've recently reached 100. For the first 7 or 8 years, we were only 4 or 5 employees in a small office in the local academic medical center. The work of the coalition, one of the first projects, shortly after becoming the breakfast group, had some students that were looking at violence in Camden, and they got access to claims data from the 3 local health systems and learned what was referenced earlier about the sort of small number of patients that are accounting for a large percentage of costs. In Camden, it was 1% that was accounting for 30% of costs, 5% for 50% of costs. And over time, that has really become our sort of central focus, is that high cost, high need patient population. We know it's varied, and it includes a lot of different things, end of life and expensive cancer treatments and so forth. But the portion of that is this socially driven expense where folks are frequently coming back to the healthcare system, the hospital system, with unmanaged disease because of the failure of our social service system, the failure of our behavioral health systems, or a combination of factors. That's really the focus of the coalition. And I think that in thinking about the coalition, what's really stands out is that it is a model of collaboration. It's an R&D model. It's got this focus on high cost, high needs patients. And then what I'll talk a little bit about for the theme of this panel is around payment and how we've tried to experiment with some of the newer payment models and both the success and failures that we've seen as a result. So we recently updated our vision and mission. We are now actually operating more on a national level as well as locally. Most of my comments will be about our local work, but my main job is running a National Center for Complex Health and Social Needs, which is really trying to grow and support the work of programs around the country that are singularly focused on this high cost, high need patient population. So over time, the breakfast group grew up a little bit and decided to incorporate as a nonprofit. It chose to become a membership nonprofit understanding that if we're going to try to focus on improving the health of Camden, we had to look not only at health care, but all the different factors that impact health. And so as you can see, you've got, as members of the coalition, we have behavioral health, home health, social services. We actually have patients and local community members on our board, primary care providers, hospitals, et cetera. And we really chose an engagement model. So the goal here is to take 3 hospitals that hate each other and fight with each other and have billboards competing with each other along the bridges and highways in and around our neighborhood, and to turn them into collaborators, at least in this space of working on what for many years was very much untapped, like how are we going to figure out what to do with this high-cost, high-need patient population that is plaguing our emergency rooms, plaguing us financially, and there are no solutions. So we have created a structure of governance that allows for many people to get involved in, from those different organizations, to see each other as collaborators, to work together to develop new solutions, to implement them, and to really change the paradigm from one of competition to one of collaboration. So I want to talk a little bit, just to frame, before I get into our programs, about one of our typical patients. So Peter is a patient that we've worked with a couple of years ago, continue to be in touch with. He's fairly typical for the kinds of folks that we see. He was someone who had lived a pretty normal sort of middle-class, working-class life in Delaware, working in manufacturing. Lost his job, went through a divorce, ended up moving to New Jersey to live with family. There were some family tragedies, and he ended up homeless, living on the streets. He had COPD, asthma, hypertension, fairly typical chronic illnesses, complicated by his anxiety and depression, and a history of alcoholism. He was living in a local shelter. And every day, when that shelter woke him up and kicked him out of bed at 6 in the morning, he would walk 2 or 3 miles across town to the local library. Winter, summer, 20 degrees, 100 degrees, he was walking that length to the library. Not surprising, he often suffered anxiety bouts, he suffered breathing problems, would wind up in the emergency room, get worked up, oftentimes get admitted. And was someone who came onto our radar because our programs are using our Regional Health Information Exchange to identify patients that have been in the hospital 2 or more times in the last 6 months and have other indicators that they're likely to return, and those are the folks we work with. So we started working with Peter while he was still homeless, and eventually were able to identify that housing was one of his primary drivers, and we had just started a new Housing First program, which I'll talk a little bit more about, but got him into housing. And this is just a snapshot of his his utilization. So going back to January 2014, and over the recurring 18 months, he visited the emergency room 18 times. He had 15 admissions. Charges from the 3 different hospitals totaled $640,000. He was finally moved into temporary housing in September while we were putting the finishing touches on his new apartment that he moved into in November. This is 2015, so 2 years ago. He's been back to the hospital once for a scheduled procedure. Other than that, he has not been back to the emergency room, not been back to the hospital. It was his housing status that was driving all of this cost, and that's a little bit of what you heard earlier today. So, and that's not atypical for our patients. A lot, as was mentioned earlier, there's a reference to the US healthcare paradox and the idea that we are medicalizing social problems, that the social safety net has really been, is disintegrating, and the place that you can go is the hospital to get when you need warmth or meals or what have you. Not to mention the impact that has on people's health. It wasn't that he wasn't sick. He wasn't just coming for a sandwich. He was suffering real episodes of illness, but illness that was easily manageable in different situations. So I want to talk a little bit about our Medicaid ACO. So going back at the same time as the New Yorker article, ACOs were still sort of a new concept, and Dr. Brenner was working with a group of advocates around the state of New Jersey to develop a piece of legislation that was ultimately passed and signed that created a Medicaid ACO in the model of the coalition, which was basically a place-based, community-based ACO. It has to have all of the hospitals within the local geography participate. It has to have 3/4 or more of the primary care providers. It has to have representation of behavioral health and social services and actual community organizations on the board of directors. A couple of things that were not as optimal. Well, first of all, that model, while it's worked wonderfully for us in Camden, is a pretty high threshold model for communities where that sort of infrastructure didn't exist. So there were 8 different communities that ultimately tried to become certified ACOs, but for various reasons, only 3 were ultimately certified. And some of that was the sort of high barrier to entry around collaboration. The good news is that of the 5 that didn't become certified, many of them have found ways of working together in much more collaborative ways than they were before. So they're not yet ACOs, but they're still very collaborative. The other thing was that managed care wasn't required to participate, so that was a barrier and has been a barrier for folks, and there was no upfront funding. So the theory was that we could do this all on shared savings, and as we've seen that without some upfront infrastructure, that wasn't possible. The good news is that in Camden, we were able to negotiate really collaborative contracts with the 2 largest managed care organizations serving Medicaid patients, have had very positive relationships, very good learning relationships between the insurance companies and the folks working on the ground. And that has continued to evolve. So I want to talk a little bit about the evolution of the programming. As I mentioned, our care management initiative is the way in which we identify these frequent users of the hospitals using an HIE, identify them while they're in the hospital, send outreach workers to their bed to tell them about the program. We just finished the randomized control trial. The results aren't in yet, but we were going through that randomization process at the bedside, but consenting them and so forth. And then they start, if you're in the program, they start to develop a care plan that's driven by the patient about what they want to do, what their goals are, and then they transition to the community. We have these 15 different domains of care, and what you'll notice about them is that only 2 of them are really traditional medical healthcare types of areas. Most of them are addressing behavioral and social health needs, things like food and transportation, identification, family relationships, housing, things like that. What we found was that for a subpopulation like Peter, managing them between their providers and between social services wasn't enough if they stayed homeless. You couldn't make an impact on his asthma if he was still walking to the library every day. And so what we did was to advocate ultimately to get funding and housing vouchers to be able to create a Housing First program. And we've housed close to 50 people in that program, and what we've seen is close to 60% reduction in hospital utilization for people in those programs. It's the same profile of people with the addition of homelessness. At the same time, we are also, as a ACO, serving 60,000, roughly 50,000 sort of covered lives in and around Camden. We're working with 15 different practices and doing practice transformation. Our old way of doing practice transformation was to send in a trained nurse or practice improvement coach to be part of the team, and what we found was that they were integrated, and then the practice became completely dependent on them, and you pulled them out and everything went back to normal. So what we've done is really changed to create a citywide approach that we call the 7-day pledge, where it's a single metric focused on folks coming out of the hospital, getting them back into primary care within 7 days. We create the data infrastructure and workflows, financial incentives, even help make the appointments for folks to make sure that practices are getting them in to primary care, and pay them to do a longer follow-up visit there to be able to reconcile meds and assortment of other things. That's created sort of a flywheel infrastructure to get all the practices working on common projects in a collaborative way. And we also have built around that a community building exercise, quality improvement process, dinners, other supports. We've provided training on addiction, trauma, patient engagement, and a variety of other things that are really helping to enhance the primary care practice to be able to better serve patients with complex health and social needs. At the same time, our coalition is building infrastructure to help folks access those social service resources. So this is an open source shared database of all the social services in the area. So if someone needs to get a referral to a food pantry or shelter or what have you, this is being maintained and is available to everyone. So those are just an assortment of the things that we're doing as a coalition to try to support the improved care for the most complex patients within Camden. And then, as I mentioned earlier, as a national center, we're trying to do the same sort of support work and convening work for folks around the country that have taken this on of really trying to develop structured models to better serve folks with complex health and social needs. I know I went a little bit over, so I look forward to more conversation. Thanks.
Thank you.